So welcome all of you. For this month's Journal Club, Dr. Sudhanshu Bansal is here on IOVA Yuva Mentor Fellowship. So he is here for 2 weeks short clinical observership and fellowship. And he said, let's do this Journal Club on pediatric infection. So he and Shalin digged out 4 interesting papers. So I welcome Dr. Prasad Gourineni and Dr. N Gupta. They are experts in this field, and I welcome you, Prasad. Thanks for your time. Gaurav, would you like to start the first paper?
Right, sir.
Please go ahead.
So I hope I'm audible to all.
Yes.
So this paper was published by our team, Orthokids team. It started during my fellowship in 18, and this publication came just now in 2021 in Journal of Pediatric Ortho, British. So this is titled as Protrusio acetabuli as a sequelae to septic arthritis
So
of the hip.
it's not British, Gaurav. It's JPOB. B stands now for the Asia Pacific countries. Where
Okay.
Dr. Ashok Johari is, yeah.
Okay, sir. Okay.
Yes, and then British thing is now JCO probably.
Okay.
Yeah.
So it is Protrusio acetabuli as a sequelae to septic arthritis of the hip with obturator internus pyomyositis. Authors include me, Dr. Kesar Rabi from Bangladesh, Dr. Vikas Bora from Jaipur, and sir. So we know that pyomyositis is defined as a pyogenic infection of skeletal muscles, principally caused by Staphylococcus aureus. It most commonly is seen between the second and third decades of life. And hip pericapsular pyomyositis is one of the most common types of primary pyomyositis. Out of this, obturator internus and externus are the most commonly involved muscles around the pelvic girdle. Before this, there was no published study regarding the sequelae of untreated pericapsular pyomyositis around the hip joint. So our purpose was to describe the sequelae of unaddressed obturator internus abscesses in 4 adolescent patients and to compare their outcome with another 4 patients where we then adopted this modified obturator approach to drain the obturator abscess along with the hip arthrotomy in cases of septic arthritis with obturator internus abscess. So we had 2 groups of patients. Group 1 included 4 patients who came to us between 2014 to 16 with septic arthritis and obturator internus abscess. We calculated we jotted down the sex, the site, duration of symptoms, the lab parameters, management, culture reports, their hospital stay, complications they faced, duration of follow-up, and we plotted the Iowa hip score to know the functions at final follow-up. Similarly, for group 2, we also had 4 patients. These were the patients who came to us after 2016. And here we adopted, till that time, we adopted the Vanderbilt medial approach to drain the obturator internus abscess, along with doing a hip arthrotomy. So this is the technique video. It has the vocals.
We are describing a modified obturator approach or a medial approach. You can talk about it. It's not very loud.
Okay. So this is a 11-year-old child presented to us with fever and inability to bear weight for 1 week. His labs were elevated. X-ray was normal. This is the MRI. There was collection in the joint, and along with that, there was collection in the obturator internus abscess.
Further axial images demonstrate that
the obturator internus abscess was communicating with the hip joint. So this
Dr. Marlin, can I just stop? Can you just stop it for a minute here?
Yeah.
Dr. Marlin,
Yeah.
can we go back a little more in the video? The first slide of the MRI of the MRI. Yeah, this one. Now, if you see here carefully, because I'm sorry, I'm stopping in between.
That's
Is it
okay.
okay? Is it okay, or should?
Yeah. It is fully interactive. So you go ahead. No problem.
So if you see here, if you see the ischial area of the acetabulum, ischial part of the, there is a
Hmm.
little whitish. I mean, it's little dense. This one, the ischial area. Yeah. No. The bone. Yeah.
Yeah.
So, I mean, I have had similar neglected patients, which we have not studied the long term thing, but a lot of times we felt that this is actually a osteomyelitis of the pelvic side, spilling over into the hip joint as well as into the obturator side.
Yeah. So I agree.
I
That's an
mean, a lot of time
osteomyelitis.
we felt like that.
Yeah, I agree with you. So if we can compare it with the opposite side, and there is increased
Yes, I mean,
signal intensity,
yeah,
but there is no collection. You can see the obturator internus is purely white and
is
liquid,
white.
and
Yeah,
it is elevated. So
I
this is
agree.
suggestive of obturator abscess and osteomyelitis, but without any collection. So we thought we can deal it with antibiotics because there
Okay,
is no collection.
okay.
Yeah. Yeah, Gaurav, go ahead.
Go ahead, please. Go ahead.
So this section shows the horseshoe-shaped abscess connecting the obturator abscess with the hip joint. So it was a child was placed in supine position with sandbag under the opposite buttock, and the hip was kept in abduction and external rotation. Vertical 5 centimeter incision was given along the line of adductor longus. Adductor longus tendon was exposed and retracted anteriorly to expose adductor brevis and the anterior branch of obturator nerve. Blunt hemostat was passed through the adductor brevis towards the obturator membrane, and then it was guided with a C-arm. Hemostat was advanced through the obturator membrane and was turned towards the quadrilateral plate and was widened to open the obturator internus muscle and the collection, and we can see that the pus has started coming in. Then the wound was thoroughly cleaned and lavaged by putting an infant feeding tube through the obturator foramen. And with this, the wound was lavaged and a negative section was placed in the wound. So to discuss the results, the average age at the time of presentation was comparable. The average duration of symptoms was more in group 1 as compared to group 2. Otherwise, the average temperature at presentation, the lab parameters were comparable. The average time for normalization of blood investigations was more in group 1 as compared to group 2. Iowa score was also significantly different. It was 69.25 in group 1, whereas it was 93 in group 2. Average follow-up was 6 years for group 1 and 4.25 years in group 2. There was, in 2 cases, in group 1, there was need for repeat drainage in the first month of the surgery. And all the 4 patients had restricted range of motion in group 1, whereas none of the patients had restricted range of motion in group 2. There was
Gaurav, sorry, which was the area for repeat drainage? Was it the obturator or the hip? You said you opened both.
So in one case, I did a repeat hip arthrotomy,
Mhm.
and in one case, I saw that there is in pubic area there is osteomyelitis with the area which so near ischial tuberosity. So we went like an posterior approach with my adult orthopedic surgeon, but we did not find any collection there. There was just marrow edema approach. So we drilled it. So that's how we did 2 cases. Both the patient presented with collection in hip. So in one I did only hip arthrotomy, and in the other I did a posterior approach as well. So we had a repeat MRI and then we did it.
You mean the ischiopubic ramus?
Yeah.
Okay.
So there was persistent limp and restricted range of motion in all the patients in group 1, whereas none of the patients in group 2. And all the patients in group 1 developed protrusio acetabuli. In 3 patients, it was grade 2, Sotello-Garza as per Sotello-Garza classification, and in 1 case, it was grade 3. So this is a case example of group 1, where there was a obturator abscess communicating with the hip joint, and we drained only the hip joint. And then these are the final follow-up x-rays showing protrusio acetabuli. Along with that, the child is unable to squat properly and sit in a cross-legged position. This is a case example from group 2, where we did arthrotomy along with obturator internus drainage. And here we can see that the final follow-up, the x-rays look pretty normal, and the child is able to do squatting and cross-leg sitting comfortably. So existing clinical algorithms are unable to differentiate septic arthritis and pericapsular pyomyositis. Different authors have reported different clinical findings which are specific for obturator externus or internus abscesses. These include increased pain in external rotation of hip, restriction of internal rotation of hip, skin lesions, and labia majorum swelling in females, whereas none of them is pathognomonic of obturator muscle abscess. What we found in our series was that patients mostly prefer to sit upright, and they denied lying down on the couch to avoid painful hip extension. And MRI is the most efficient tool in distinguishing these two. Till date, there was no literature which reported protrusio acetabuli as a complication of obturator internus abscess. As we know that obturator internus arises from the rami surrounding the obturator foramen and the quadrilateral plate, and untreated pyomyositis of this muscle can lead to erosion of the quadrilateral plate, making it thin and weak, and this may have caused medial migration of femoral head on weight bearing and protrusio acetabuli in our series. To conclude, the possibility of pericapsular pyomyositis should always be kept in mind in older children with acute hip pain, and a high index of suspicion is required for its early diagnosis. MRI is the gold standard investigation for confirming diagnosis and planning, and a safe and effective surgical drainage of obturator internus abscess through a minimally invasive Vanderbilt medial approach may prevent long-term sequelae of chronic pain, protrusio, and secondary osteoarthritis. So I would like to acknowledge Dr. Prasad, who was very, very instrumental in compiling the manuscript and editing our manuscript. Thank you, sir. And this paper is open for discussion.
Yeah.
So Gaurav, two points that came across in my head. One is the delay. You pointed it out already, right? There's about a 13-day delay in presentation and treatment.
Right.
In group 1, right? So that's a variable. Now the important thing is, how often do we see protrusio in septic arthritis sequelae without abscess formation, right? That's a comparison that will be useful. Obviously, it's not within your scope. I have seen 1 or 2 cases where there's simple septic arthritis. I don't know if they had an abscess or not. They came long-term for my treatment, and they had protrusio. So they may be, right, delayed treatment may be a risk factor by itself also. But you proved well that if you drain both abscesses, they do well. So it's an important paper.
Right, sir.
So mostly what happens, Prasad, we in early practice, and Dr. Gupta will also concur with that. the late presenting septic arthritis, mainly they lead to chondrolysis. And the main changes are more on the hip side or the femoral side. And we seldom see the acetabular thinning and protrusion, but it was seen in all the 4 cases.
Right.
The story started, when I attended POSNA in 2015. There, Jonathan Shoemaker, he presented this approach. And by that time, I burned my fingers with these patients because I had brought them repeatedly to theater and the parents were not happy. And it suddenly struck to my mind that my patients who were not doing well, they also had similar MRI findings. So I went back and see, and all of them had certain degrees of obturator internus abscess, but your eyes don't see what your brain doesn't know. So I always thought that there's just an edema, and once I drain the joint, the antibiotics will take care of it. But that needs to be drained, and that we saw in our subsequent 4 patients. And after that presentation of technique in POSI, I must tell you that almost 15 colleagues of our POSI group, they called me before doing an obturator abscess drainage, because it's a scary approach, where we always found some obturator vessels there. So they always call me, Molin kaise hota hai, kharab nahi ho jayega. It is swollen and you just put your blunt hemostat and it will drain. And so I think by now a lot of POSI colleagues have used this approach. And so the key point which I always tell my fellows is, when an older child or adolescent presents with signs of septic arthritis, just don't go right away in with an ultrasound only. You have to get an MRI, because on ultrasound you will not be able to see this obturator internus abscess. So MRI should be done.
Malin, can I add something?
Yes, please.
Malin, we did a study on 20 patients. This was a thesis given to one of my students. So this was about 3-4 years back, perhaps 5 years back.
Yeah.
Now, 20 consecutive patients, we saw that our results were similar to what McNamee had reported. Something similar, but a little different. The septic arthritis, pure septic arthritis, was in out of 20 only in two patients. I'll not remember offhand, but it was in 2 or 3 patients only. And all these 3, they were less than 2 years of age. Right.
So
There were
was their
patients.
age? What was their age? Sorry.
Less than 2 years.
Or younger children.
Yes. And all the rest, they had either pericapsular pyomyositis or osteomyelitis.
Okay.
Of the I think 2 were pelvic side, and 3 or 4 were the femoral side. And they were presenting with symptoms similar to septic arthritis. So the genesis of this MRI is that, few years back, most of my residents, they used to, what they do is, sir, septic arthritis का केस आया है, हमने खोला कुछ मिला नहीं सर उसमें. And then we came across this paper of McNamee, and then we said that a lot of patients are this much distribution. I think in our series it was like around 60-65% pyomyositis, and just about 5 to 6%, 6 or 7% were pure septic arthritis. And to add on to that, 2 patients of pyomyositis, they developed a late septic arthritis.
Yeah.
Yeah. So
I like to share one thing, intraoperative finding which I saw, that when there is communication of obturator internus abscess to the hip joint through lysosciatic notch.
Yeah.
Once we drain the joint and you flex and extend the hip, the pus will trickle in. You flex and extend, the pus will trickle in. So the first time when it happened, I I said, I thought that I have irrigated the whole joint. Why the pus? Where the pus is coming from? So my nurse has, when we lavage, my nurse has a tendency to flex, extend, rotate. So when you flex and extend, the pus will trickle in. So this is again a sign that this obturator internus abscess is trickling inside the joint. If you find more pus coming with flexion extension movement, this drains through the sciatic notch. So this is the finding, and this is the reason why as a pus keeps on trickling in the joint, even though you have drained it, it will present again as a signs of septic arthritis.
Yeah, I think yeah.
Sorry, I just wanted to check, ask a question. Molin?
Yes. Who is this? Sorry.
This is John Mukhopadhyay from Patna.
Hi, John. Sorry.
Hi, how are you? Yeah, no, so I just wanted to check because I think it's a great paper because I can think of cases where in the older child, we've gone and drained the hip, found synovitis and maybe a little bit of pus, and the clinical findings were not correlating with what we saw on surgery. And looking back, these could be cases of obturator internus. I can't recollect whether we looked at the MRIs very closely or not, but I can think of at least 2 or 3 cases where maybe it was something like that because they took a long time to recover, even with antibiotics, etc. Unlike septic arthritis, where once you drain it, it seems to get well within no time at all. So it's interesting. I think it's certainly something which we need to look at very carefully.
Yeah, especially in adolescents.
Yeah, especially in this older child group.
Older
Is
child, yeah.
10, 11, 12, 13.
All the patients in our series are more than 10 years old.
Yeah, I can think of at least 2 or 3 cases in the last couple of years where we may have missed it.
Okay, so let's move on to the next paper. Sudhanshu, you want to read your paper?
Yes, I'll.
Yeah, please share your screen. So Dr. Sudhanshu is a practicing pediatric orthopedic surgeon in Amritsar, and he is here for a short fellowship at Orthokids.
Thank you, Malin sir. Good morning, everyone. My topic is false negative joint aspiration of septic arthritis of the hip in neonates. This is published in JPOB November 2021 edition. It is a level 4 retrospective study. Timely diagnosis of septic arthritis in neonate is challenging because of their age and the masking presentations. Joint aspiration is very diagnostic procedure for these kids. But if the aspirate is false negative, then delay in the treatment may lead to devastating results. So it is very critical to diagnose and treat septic arthritis to prevent this irreversible damage. There are many diagnostic protocols to diagnose septic arthritis. Joint aspiration is a standard diagnostic procedure to see the type of fluid, how the effusion is, and to culture it to know what is the organism. The aim of this study is to investigate clinical course of neonates in septic arthritis of the hip, despite initial negative finding on joint aspiration. This is a retrospective study. They selected neonates who were diagnosed with septic arthritis and who had negative joint aspiration. Still, they treated them between 2003 to 2013. Out of 57, they selected 6 neonates. 4 were male and 2 were females. Mean follow-up was 12 years and mean age at onset was 16 days. They included those kids who were less than 1 month of age, whose the aspiration was negative because they showed scanty fluid or no results on aspiration, and at least 5 years of follow-up was there. They excluded neonates with tubercular infections due to open injury. X-rays, labs, ultrasound, and ultrasound-guided aspiration was done. If clinician desires or if the at clinician discretion, MRI was done. MRI was evaluated for joint effusion, bone signal changes, joint subluxation, any extra-articular soft tissue edema, or any presence of extra-articular abscess or pocket. The diagnosis was based on modified Kocher criteria, 3 out of 5 criteria. If met, then diagnosis of septic arthritis was made. Follow-up was done to evaluate the assessment of the subjective complaints of the patient, how's the joint range of motion, and it was scaled from excellent to poor. Anatomical changes in the radiographs was also classified according to Choi et al. System. The main duration between the onset of the symptoms and aspiration was around 11 days, and between the onset of symptoms and surgery was around 15 days. Intraoperative findings, they had all the kids were having a capsular rupture and instability with subluxation of the hips. The minimal amount of fluid was found on operative intervention, and two kids had interposed granulation and fibrous tissue. So they gave parental antibiotics according to the culture, and immobilization was done first in spica and then after in brace. Most common causative organism was Staph aureus, MRSA positive and susceptible both. These are the demographic data of the 6 kids. All have negative aspirate, and out of these 4, there were extra articular abscess. 4 were having extra articular abscess pockets. Among these 6 kids, 4 ended up having were required another reconstructible surgical procedure like femoral lengthening, femoral varus osteotomy, epiphysodesis, femoral valgus osteotomy, pelvic osteotomy. This is an infant who presented with hip irritability at 13 days of age. MRI was done at 17 days, and there was an extra articular collection was found, periarticular abscess pocket, which was continued with the left buttock. This kid at 4 weeks, bone resorption of the proximal figure was observed. On arthrography, epiphysolysis was seen at 6 years. They have done femoral lengthening as 5.7 centimeter of shortening was there. And later on, they did this valgus osteotomy and derotation osteotomy to preserve the joint. Effusion is scanty or absent. Maybe the reason is like early stage, as various studies have given different reasons. Like early stage, maybe the effusion is not developed yet. It is established stage, the effusion has resolved, or it was not septic arthritis on the first day, it was isolated osteomyelitis, or there, because of the intra-articular pressure was so high that the capsular perforation occurred and the extra-articular drainage happened. The fluid was organized in a granulation tissue, and so on attempt to aspirate, the fluid couldn't be aspirated. These are the various studies who has documented various reasons for the same. In this study, the less than 24 hours was the presentation, and there was no effusion, only pain was there. And among these two studies, like this study and this study, they prove that they have shown that there is a perforation of the capsule, which could be the cause for scanty effusion. So limitation of the study is it is a retrospective study, small sample size. They have not taken into account the subtle signs that may be resolved, or they are subtle because of the antibiotic given by doctors. Ultrasound associated biasing was not considered. Maybe they have missed some thing in the ultrasound timing of MRI. Maybe the septic arthritis has resolved by the time MRI was done. Application in practice is that negative joint aspiration is not a sign that septic arthritis is not there. They should be aggressively investigated and proceed accordingly. Longer follow-up is required in neonate as compared to adults, because in adults, as paper says, that after 1 year, if there is no complaint, then we can stop following up the patient. But in neonates, even after 3 years of follow-up, they found changes in the joint. So they need to do reconstructive procedures. Thank you.
Yeah, so Sudhanshu nicely read paper. Which journal it is published in?
Sir, Journal of Pediatric Orthopedics B, 2021 November.
No, it's a recent one.
Shalin,
Prasad,
can
yeah, Gupta ji, please.
Yeah, I think I'll agree to Dr. Sudhanshu that a lot of times what all we see in our practice, in my practice, is that there are neonates who come with some sort of sepsis which has been treated by a pediatrician, and they land with you about 10 or 12 days or 15 days or 20 days sometimes down the line. And when you see, you feel that clinically this is looking like a partially treated septic arthritis or or partially responsive septic arthritis, whatever you call it. If you take a ultrasound, you find minimal fluid into the hip as compared to the contralateral side. And if you see the MRI, you will find some synovitis at the hip. Once you open up, you really don't find much of collection there. I mean, we have opened up these cases.
It's a burnt out disease.
So it's a burnt out disease, but still, if you don't actually open it, they'll sort of keep on lingering a little. So we tend to debride the joint a little, though we have not done any study in this regard. But the ones which we have debrided, we feel that they tend to fare a little better. But only issue is that whatever vascular damage has occurred, that uncovers over a period of time. This is what I feel.
Yeah. So like the purpose of this journal club is twofold. The first is the quality of paper, and the second is the applicability, whether the inferences are really applicable to our practice. So Prasad, what is your comment? And then I'll tell what I feel,
Well, first thing I have to say is these two papers are teaching me a lot of things I didn't know in 25 years of practice. I haven't treated a single neonatal septic arthritis in America in 20 years of practice. No NICU infections. Never saw a single one. I was the only pediatric orthopedic surgeon for 15 years in that hospital. At a level 1, top level NICU. I never saw a single one, right?
Yeah.
So my experience is so limited. I see so many sequelae in India that I'm learning actually from you guys. Second thing is, why are things being delayed so much in spite of all this advance, right? I mean, you don't see any at all. I never treated a single septic sequela in America. I never seen a neonatal thing in America. Why are we not improving in India? That's my main amazing question I have.
So we all young, when we were young, pediatric orthopedic surgeon, we always ride on a white horse every Sunday to teach pediatricians that the antibiotics are false umbrella when it comes to septic arthritis. But unfortunately, we see a lot of neglected cases. There are also top level NICU units, but there are also some pseudo NICU units where sometimes we see the patients are admitted for physiologic jaundice and they end up with a septic arthritis hip because of cross infection. So that is another story which we have to, we are struggling and we are working on it to increase awareness. But we see this. Now, I have never based my decision on aspiration. So what I think is the 5 patients which the series mentioned is 16 days, 14 days, 14 days, 22 days, and 25 days. So by that time, the fluid or the pus will not be there. It would be organized granulation tissue, or it would have destroyed the joint. And so you are not going to get anything on aspiration. So there is no question of doing aspiration in those cases. So this is a very poor study, I would say. Only 6 patients. These are 6 patients which have been followed for long, and the author wants to show what hip conservation or big surgeries they have done. But 6 patients will not tell you the strategy of dealing with this problem. You cannot, based on these 6 patients, that negative aspiration does not mean that you don't have to operate. Of course, that we know that if aspiration is negative, either it's a very early disease or it's very late disease. But the conclusion which are made, it's not in a right way. So to all youngsters, like in children or in neonate, when a joint is flexed and you should get an ultrasound, an ultrasonologist can tell you if there is intra-aortic collection or there is adjacent osteomyelitis and periosteal elevation. You cannot have anything else but septic arthritis. And the treatment should be arthrotomy, because sometimes, the families, they notice these things pretty late. Many of them are NICU graduates. So the main focus of doctors is on more vital areas and they miss this. So these already are late cases. So do not just do aspirate and see whether it is pus is coming out. You have to drain it, and sometimes you will not find fluid, but an organized pus flex, which you have to take off. So John, your comments, yeah.
So there are a couple of things here. So we see a lot of this, okay, where they
Yeah.
come 2 weeks, 3 weeks down the line. The problem is some of them are actually recovering with the antibiotics. And then it's a big decision whether you want to go and drain them or not. And that would be really the vital question that if we can find the answer to that, because some of them actually get better. They might have some minor sequelae, but then they would have that sequelae even if you drain them.
Yeah. So I agree with you. I had twins who were graduated from NICU. Now their CRPs were normal. They didn't have pain. The only presenting symptom was they kept their hips in flexion.
Exactly. They don't move it a bit and then...
When the supported standing is done, the child keeps one leg flexed at hip and one. So what they had is some organized collection, but at the same time there was anterior structure tightness, like tightness of anterior capsule and the rectus and all. So in those cases, I required to release, and they are kind of burnt out disease, and probably you don't get much in the joint, but to make them straight, you might need to do some anterior capsular release and soft tissue release.
Yeah, the problem with those is that even after surgery, they're going to have some sequelae.
Yeah, absolutely.
Yeah, so that is the big decision.
I agree.
Parents, once you want to do surgery, they want that hip to be okay. And that is one of the issues.
So that needs to be explained to them. And I know they have selective hearing, but still. So
just to get to your point about not seeing it in the US, you mean you don't see the sequelae, or you're not seeing septic arthritis at all?
No neonatal septic arthritis in 50 years in our NICU, 15 years in our NICU, where I was the sole pediatric orthopod to call every day.
That's hard to understand because, I mean, I remember when we were in England, we saw quite a few of them. A lot of the NICU patients had it. And I mean, of course, they would aspirate it and start antibiotics. If it was within 48 hours, some of them would recover. Here, the problem is they come to you after that time frame. So then it's
right.
Or of course, that Mount Sinai Hospital was a biggest NICU unit in 60s, and we often used to go there and deal with those patients.
Aspirate the hips, etc.
But the quality of NICU care also plays a significant role. Most of them are cross infections in neonates. We see some gram-negative fungal, which shows that these are very severe disease and immunosuppressed thing. But the NICU care is a key thing. Yeah. So Sudhanshu is a nice.
Malin, I would like to add, there are some factors which are not only medical, there are social factors also.
So Raman,
like we have good.
So Raman is in Edmonton at the moment, and he is mentioning that we too see septic arthritis, septic hip. So Prasad, were they referring someone else? You are an adult.
No way. I was the only one taking call every day. But anyway, let me tell you this about anecdote. Jayan Sampath told me that in the rain in the hospital, one hospital where he works, there's no neonatal septic arthritis rarely. And next door in Indira Gandhi, they drain 2 or 3 every day.
Right. Yes, what is
what I was saying is that it's not only medical aspect, there is a social aspect also.
Yeah.
Like we are in a government setup, and in a government setup, a lot of times the NICUs, they are overburdened. So it is a possibility that I'm sure that is the scenario in most of the places in government sector. And a lot of times they tend to, evade the watchful eyes of the neonatologist sometimes. And lot of government sectors, they may not have a neonatologist where a pediatrician may be filling the gap for a neonatologist. So these are some of the factors which could lead to a higher incidence in India. That's what my understanding goes.
I think we really need to make our pediatricians aware of this. That is the big problem.
Yeah.
Because they continue giving them antibiotics.
Yeah, I agree.
Improve, and then they get IV antibiotics for 3 weeks and 4 weeks, and some of them actually get better and they think it's okay. But we really need to get them to refer these to us earlier or have some kind of communication with them.
So I happened to attend one infection CME where there were case presentation going on. Senior pediatrician of Ahmedabad, they were presenting. And I saw they are very fond of showing the timeline. So we gave this antibiotic for first week and CRP day. So we started other and then the third. So what I saw that in systemic sepsis, they have to change antibiotics. There are no collection. There's an infection in this synovium. But osteoarticular infection is when there is collection, there's a lot of intra-articular pressure. So antibiotics will not reach there. So you have to drain it right away. So it seems that they are confusing osteoarticular infection with the systemic infection, and they have the same approach. And we see a lot of referrals. Sir, 5 days I give that. And anyways, Gupta ji, I think there are 2 more interesting papers and we'll run.
Malin, then I need to leave.
Oh, okay.
Meeting. Okay.
Okay, thanks.
I'm traveling actually.
Okay,
I'm traveling, so need to go back.
Yeah.
Okay,
so thanks for your time and thanks for lovely comments. Yes, Shalin or Chinmay, who would like to present the third one?
I will present.
Yeah.
Good morning all. Myself Dr. Chinmay. I am presenting today's paper from JBJS July 2021. The paper was conducted at Children's Health System of Texas. The paper is about the children with primary septic arthritis have markedly lower the risk of adverse outcomes than those with a contagious osteomyelitis. So, in speaking about the background or the introduction of this paper, that there is an identification of combination of osteomyelitis with septic arthritis is important because this will lead to sequelae in the form of osteonecrosis, chondrolysis, joint destructions, and a growth disturbance. Most of the paper are studied and showing the result only of the osteomyelitis, but they don't specify about the septic arthritis associated with the osteomyelitis. So they come up. There are some literature which shows the algorithm which is based on MRI and bone joint aspiration. So in MRI, which was published in JPO 2020, which shows that the septic arthritis is not getting corrected. There's a prolonged fever. We'll go for the MRI to look what is inside the joint. Similarly, if there is a MRI is negative and a joint aspiration is negative, the joint aspiration is negative, they go for the bone aspiration and to look for any osteomyelitis in the bone. So aim of the current study is to compare the children who had a primary confirmed septic arthritis with those who had osteomyelitis with contagious septic arthritis to guide the decision making and to assess the relative risk of the adverse outcome. In materials and methods, so this is the extensive study was conducted between 2009 to 2019. In inclusions, they see the septic joint which was confirmed on the USG, the fever, the blood parameters, the CRP, and the ESR levels. In exclusions, there is a penetrating inoculation of the joint, surgical site infection, or immunocompromised, limited follow-up, or non-isolation of the pathogens. So they define the septic arthritis and osteomyelitis by the definition that the septic arthritis are the joint fluid culture or a 16S ribosomal RNA gene polymerase chain reaction positive pathogens, and they define osteomyelitis as the positive blood culture or a bone aspiration or debridement cultures. They define as the osteomyelitis. So in a result, there are total. They divided the children into 2 groups, that is primary septic arthritis and a septic arthritis with osteomyelitis. So total 631 osteomyelitis children were enrolled during this 10 years follow-up. So out of which 105 have the septic arthritis. In a primary septic arthritis, total 268 patients, out of which 134 patients pathogens are identified and they were included in the study. So this is the extensive tabulated form which they presented in the paper. But some of the important points which is important for in the clinical practice and this paper is the delay from the onset of admit. That it shows that septic arthritis with contagious osteomyelitis have a delay in admission around 7 to 8 days as compared to the primary septic arthritis, that is 4 days. Then the initial CRP is also high in contagious osteomyelitis, and the peak CRP is also high in a septic arthritis with the contagious osteomyelitis. The initial platelet count, which is low in osteomyelitis cases. The joint, of course, in the septic arthritis, the joint fluid cell count is increased in a primary septic arthritis. Delay from triage to surgery in the form of hour. Septic arthritis, they drain in a day, but associated osteomyelitis, they wait for the day or half. Febrile days on antibiotics was 3.8 days, and for septic arthritis is for 1 day. Readmission was 4 days in a contagious osteomyelitis, but in a septic arthritis is only 2 days. The total duration of antibiotics were extensive for the osteomyelitis, which shows that 67 days, but for the septic arthritis is only for the 30 days. In comparison with the discrete variables, the trauma is a significant finding in this paper, which suggests that the septic arthritis with contagious osteomyelitis have a 41% of the preceding trauma, which presented in this study. The initial thrombocytopenia was significant in osteomyelitis patient. Confirmed septic arthritis was 100% in a primary septic arthritis, but 90% in a contagious osteomyelitis. MRI is awkward because the patient is not improving on the surgical drainage. There is a persistent prolonged fever and there is elevated inflammatory markers. So they go for the MRI, which is of a 89%. And the readmission was obviously more in a contagious osteomyelitis, and the complication occurrence are more in contagious osteomyelitis. So this is the scoring parameter which they given in the paper, which was published in JPO 2019, which these parameters were divided into mild, moderate, and severe. So these parameters are basically useful to look for the child which needs an NSU admission and which requires a long-term follow-up to look for any sequelae. So this parameter is useful for in our clinical practice also. So speaking on to this paper, that contagious osteomyelitis have a mean score of 5.4 with standard deviation of 3.4. The primary confirmed septic arthritis score was 2 with standard deviation was 2.2. In evaluation and treatment, the primary septic arthritis, Staph aureus is the most common organism. Out of 43 cases, 4%, 9 is having the MRSA pathogen. In children with osteomyelitis, out of 81 cases, 45 has of MRSA positive cases, and they show that the PCR, polymerase chain reaction, has a sensitive method to detect the pathogens in both the septic arthritis and the contagious osteomyelitis cases. In a complication, only one primary septic arthritis having the epiphyseal osteomyelitis, and the rest all the all the complications are come in the osteomyelitis cases in the form of osteonecrosis, pathological fractures, and central fascial tearing, and all the protrusio, limb lengthening, epiphyseal deformity, joint subluxation, joint contracture, etc. In a discussion, the sequelae prone child in historically was have a bad prognosis, so they go for the MRI. The phenomenon of combined bone and joint infection, which theory suggests that the metaphysis which is intracapsular, showing the septic arthritis, will go for the osteomyelitis, and the osteomyelitis will go for the septic arthritis. In these studies, the 13 of 105 patients, subchondral and epiphyseal osteomyelitis, average delay from the symptom onset to hospitalization was 18.8 days. Similar, but the metaphyseal osteomyelitis average delay from symptom to onset of presentation is of 4.7 days. Primary confirmed septic arthritis average is 4.7 days after the symptom onset. Primary septic arthritis treat beyond the 10 days to concern of the potential failure to recognize foci of contagious osteomyelitis without MRI acquisition. So they go for the MRI for the children with suspected primary arthritis if there is a causative organism with Staph aureus, initial or sustained bacteremia, prolonged fever, and multiple surgical procedures. The primary septic arthritis treated for 10 days following a solitary joint aspiration without surgery. So these are the two papers they quoted, that how many days we can treat the patient for the primary septic arthritis and children with the osteomyelitis. So the children with the acute hematogenous osteomyelitis are treated for 20 days with a minimal need of surgery. But in their study, they come up with this algorithm which shows that the septic arthritis and a contagious osteomyelitis with the clinical findings suggest to when to go for the MRI and how long we can treat this patient with the antibiotics and what are the frequent follow-up. And we can see that if the contagious osteomyelitis is there, the follow-up duration is sufficient to detect the complication, which are up to 2 years. But here they on a septic arthritis only consider for the ESR level, but the CRP level is not mentioned over here. In a conclusion, older children with a sustained bacteremia, persistent elevated inflammatory markers, and prolonged fever require the MRI. The present study demonstrated that a long-term adverse outcome in children with septic arthritis are likely due to contagious osteomyelitis. MRI acquisition, duration of antibiotic therapy, and a length of outpatient follow-up in order to recognize an adverse outcome are required. The limitation of the study is the extensive antibiotic therapy that they around 60 to 70 days they are giving antibiotics in a septic group and little bit more in a osteomyelitis group. The role of ESG, as a study in Orthokids, that role of USG is very important in septic cases. If you look for the subperiosteal collection, it will also give you the guide that there is a subperiosteal collection. It might involve the bone also. And the CRP monitoring is also not mentioned properly over here. In application in the practice, the scoring system, which was published in JPO, which will be take into consideration while treating this patient, which will give us the idea to which patient we will need to follow up longer. MRSA patients need a longer follow-up to look for any bony deformity, and long-standing septic arthritis, the epiphyseal osteomyelitis will look for the consideration. Thank you.
Yeah, so what, I mean, it's an extensive study, lot of parameters they have used. So although they have tried to derive an algorithm, it becomes very difficult to follow. So algorithm is to minimize your or cone down your possibility. When you come out with so many parameters, then there are high chances of failure of following that algorithm. See,
yes.
The implication is the patient where the child is not weight bearing, child is not allowing you to touch the limb, running high fever and high CRP, and it looks like a septic joint. You drain it and you don't treat the osteomyelitis which is present, and then the joints which are where the metaphysis is intra-articular, then they can have a recurrence of sepsis. That's one, and they may have changes in the bone later on, or sequestrum formation, and then they may have all varieties of complications. So the key message should be, what are the findings which would suggest that this child may have associated osteomyelitis? And they have found that CRP is very high based on this thing.
Yes. But it's here 19 only, sir. But
so that's not that significant, right?
Yes, sir.
One thing which I have observed in MRSA infections, where there is common association, they have extensive swelling along the extremity because of the liberation. The MRSA toxins are locally very aggressive, produce a lot of inflammation, and at times they also produce the venous thrombosis. So when you see an extremity bit swollen in septic or isolated septic arthritis, child is symptomatic, but the extremity is not swollen because the disease is limited to the joint. But when it is associated with the bony infection, you will see the joint swelling along either in the upper thigh or in cases of tibia, upper tibia and lower femur. So those cases I like to do MRI. And younger children, as you said, we do ultrasound. Children more than 10 years anyways, see the common age of having septic arthritis is up to 5-6 years. Beyond that, if you find patients with limited issue more than 10 years, always do an MRI. And if you find subperiosteal collection and some marrow edema, there is no harm in putting another incision.
Yes, sir.
So this is my way of differentiating. You tell us based on this paper 3 or 4 things which will guide you that this is septic arthritis and this is septic arthritis with osteomyelitis. In nutshell, no more discussion, just 4 points.
Yes, sir. The first point is that the scoring system that is showing that I think that it will be useful. The second is, sir, that the intracapsular will look for the infection, intracapsular collection will lead for the metaphyseal involvement as well. So always I will ask the sonologist to look for the any subperiosteal collection. But from this paper, I don't interfere how to differentiate clinically, because clinically they are not giving us all the signs.
Yeah. So when the metaphysis is intra-articular, you know, we are not sure that metaphyseal osteomyelitis has led to septic arthritis or it's a primary septic arthritis. You know. Anyways, Prasad, your comments?
Yeah, yes. So this particular paper, you guys reviewed it quite well, but I saw 2 observations that weren't mentioned. They conclude actually that osteomyelitis is probably the primary in their patients, and that probably went to the joint afterwards. And they're saying it's a separate entity.
Yeah.
Primary osteomyelitis going to the joint. And septic arthritis rarely went to osteomyelitis because we're treating them early in America, right? You treat them in the first few days. I know they had some delay 3-4 days, but in my practice, they come and that night we brain them up right away.
Yeah.
So overall, looking at all these papers, I got two conclusions in my head. The one is treat them early, which you all agree, right? Treat them as early as you can, minimize complications. But you need to develop an MRI protocol in your head. Anything that doesn't sound like a routine septic arthritis early on, think about getting an MRI so that you don't have to go back again and again to the OR. Look for abscesses, like Jonathan Schonecker, who talked about MRI in everybody in Vanderbilt long time ago, but has not been our experience in America, in Chicago. We don't get MRIs right away. We get MRIs only when they're not responding the way they should. After 2 days, CRP is not coming down, they're not doing well clinically. That's when we get an MRI.
Yeah.
So MRI probably we should be more aggressive in getting MRIs more often, I guess, to look at all these abnormal presentations.
The second problem of MRI is, you know, when there is excessive bone marrow edema, it will, I mean, you may interpret it as a collection, you know, so it's kind of, sometimes you look at the MRI, you try to drain it and then you don't find much abnormality. It's just an edema. So you have doubted whether antibiotics would have taken care of that or not. Anyways, but my protocol for osteomyelitis, if it is not responding in 48 hours with the high-grade antibiotics, then we have to consider that we have to drain it, you know. There should not be fever spike, there should not be increasing pain, and then the CRP should be followed. Any comments from any other delegate, or we can move to the next paper? Fine. Yeah, Shalin, share your paper now. Share your screen. Thanks, Chinmay, for your nice paper.
Yes. So there's CRP.
But I know. There are, because probably in 2009, I think they might not be using, even in Coker's initial criteria, he has not mentioned CRP. They used ESR, and later on there was another paper which added CRP. You know?
Good morning, everyone. Today's paper is arthroscopic treatment for acute septic arthritis of the hip joint in pediatric patients 10 years or younger. It's a paper from Istanbul, Turkey. It's a retrospective study. So with this paper, the authors have tried to evaluate the results of arthroscopic treatment for acute septic arthritis of the hip in children 10 years or younger. So in a short background of this treatment, septic arthritis of the hip is associated with a lot of complications, as previously mentioned in the previous papers. Arthroscopic treatment is common for knee, but not for the pediatric hip. And recent years, besides arthroscopic treatment, besides open arthrotomy, USG-guided needle aspiration and irrigation has also been used and mentioned in the literature with variable results in different papers. So this was a retrospective study carried out from 2014 to 2017. And they included all cases where subadductor arthroscopic treatment was done for the pediatric hip. At least 2 years of follow-up of children was present, and they included patients who were positive for Vogel and Coccus criteria, which was modified by Michel Caid. So they excluded fungal infections, late presentations, osteomyelitis, which was diagnosed in the follow-up period, primary radiographic changes, underlying immunocompromised or neuromuscular conditions, prior surgery, and cases which were diagnosed to be reactive arthritis at the follow-up, or cases who were lost to follow-up were also excluded. So there were a long list of exclusions. So based on this, they had initial 23 patients who were acute septic arthritis of the hip. Out of these, 2 were excluded because they were lost to follow-up or incomplete follow-up. 3 were excluded because one was late presentation, one had a history of prior hip surgery, and one had neuromuscular pathology, which would alter their evaluation, clinical evaluation result at the follow-up. And 3 were excluded because one was having fungal infection, one was reactive arthritis, and one developed concomitant osteomyelitis at follow-up. So in all, 15 patients were included. Routine hip radiography, X-rays, and ultrasound were the primary preoperative investigation which were done for evaluation of the hip. And as shown in the picture, an anterolateral portal and a subadductor portal were utilized. The subadductor portal was utilized for visualization, and the working portal was the anterolateral portal where a shaver blade was used. So they did not use any traction in this method. This was the difference in the, this was the difference in their arthroscopic treatment. They used only 2 portals in place of the standard 3 portals, and they did not use continuous traction in these children. So in a flexed and abducted position, a medial subadductor portal with a 2.7 mm 70-degree arthroscope and an anterolateral portal was used as the working portal, as shown in these images. So the post-op protocol was weight-bearing as tolerated immediately post-operatively. Drain were removed at 24 to 72 hours based on the amount of fluid that was drained. And they started IV broad-spectrum antibiotic immediately and thereafter according to the culture. And they were continued until resolution of symptoms and the markers. The results, the average age in this study was 5.2 years with a range of 2 to 10 years. As it is common, the most common organism was Staph aureus. None of the patients needed additional surgical intervention or repeat debridement. Mean stay was 4 days. Antibiotic antimicrobial agents were given for 34 days with a range of 26 to 45 days. All patients had full range of movement at the hip joint, and they had excellent clinical outcome, which was evaluated using the Harris-Hip score and the Bennett score. And they, at 2 years of follow-up, none of the cases had any complications. So this is a brief outline of the preoperative evaluation, and all of these cases were Coccus criteria positive, with the youngest patient being around of 2 years and the oldest being 10 years. And this was the postoperative evaluation, the laboratory evaluation, showing most common organism being methicillin sensitive Staphylococcus aureus. There was one case where the bacteria and aspiration fluid were negative, which turned out to be Kingella kingi. And this was the spectrum of the patients they had in the study. So they have compared this study to different previously mentioned studies. The first 3 studies, first study in 1983 by Chung et al., they studied in 9 patients and used a 3-portal approach, and none of them had any complications. Another study by Kim et al. With 8 patients did not have any complications, and Nussim et al., a study of 6 patients, did not have any complications. The approach which they have used, which is 2-portal approach with 70 degree scope, was also studied by Fernandez et al., which is a study of 23 patients where 22 had excellent results, but 3 required debridement because of underlying osteomyelitis, which was found later on. Sanpera et al. Had also 2 portal approach where 12 patients were studied and 11 had excellent outcomes and 2 also required repeat debridements. In this study, they have mentioned that because the operating surgeon was a senior surgeon who routinely was well versed with hip arthroscopy, they have not experienced any complications or any requirement of repeat debridement. They have also compared the study to LSAT study, which is a comparative study between arthroscopy and open debridement of the hip. And they have a similar shorter mean duration of hospital stay. And AVN rates in the literature have been mentioned up to 50%, but the literature also mentioned that AVN rates are seen in cases where underlying osteomyelitis is there or the primary cases present late, both of which were excluded in this study. So they have mentioned their limitation that it's a small number of patients were included. It's a retrospective study, and the follow-up period was just 2 years, which might not be enough for development of late complications in these children. However, on analysis, they have excluded osteomyelitis retrospectively. Those cases which develop osteomyelitis, they have excluded from the study after the surgery and not prior to the surgery. They have considered that those cases might have had osteomyelitis even prior to debridement and not because of the approach or the surgical procedure which they have used. They've used Harris's score for evaluation in children, which where some points would not have been easy to utilize in 4-year-old children. For example, Harris's scores utilizes the duration or the distance which the child can walk after the surgery, which would be difficult to use in children. Most of the studies previously mentioned have just used a range of motion and daily activities to be carried out by the child as evaluating criteria. So, thank you.
Very nicely read paper, Shalin. I always suggest when you read a paper, you read like a lawyer. And when you treat the patient, you treat like doctor. So you have to have habit of reading between the lines. And as Dr. Benjamin Joseph said, don't read the abstract, but read the tables and you'll come to know whether it is, well, what is the limitation, you know. Fine. So Prasad, I have a few questions. You have been using scope for training or I have a few questions that while we use these 2 portals, what is the chance of nerve injury in very young children? Because subadductor portal may injure this the obturator nerve. So what is your experience on this?
All right. So I've been doing septic hips scope almost probably 15 years ago. I started doing it.
Yeah.
So Shalin, very well read paper. Excellent. Right? You covered everything really nicely. Subadductor portal is something I haven't done, but it's very safe. They're going between the sciatic nerve and the obturator nerve. So they know nothing is at risk with the subadductor portal. It's like, just like doing in front of the hamstrings, the sciatic nerve is protected behind, and the obturator nerve is well protected by the brevis and the magnus. So the portal is very safe. The problem is it's so close to the perineum. I don't like to do it unless I have to. Like adductor tenotomy, you have to go there. That's the only place to go. But why do a portal there?
Yeah.
Subadductor, so far down, close to the perineum, which has no advantage in my opinion. Second thing is, they said there's no traction. There's no way you can go between the sternum and the head without traction. They're using manual traction. They're abducting, flexing to 90, and then ask somebody to pull, which is tricky, right? If you have an instrument in there and your traction is let go, head can be damaged.
Yeah.
So it's not, in my opinion, it's not a very good technique to use. And their other portal, the anterolateral portal, is something what we use for routine, right? So we published a paper in JPOB about probably 6 months ago about our technique, single portal. So single portal, that anterolateral portal that you described, that superior anterolateral portal, or modified entry portal. That's something well described before. That portal allows you to see everything nicely, does not damage anything, no traction, and you can wash out with one portal in and out, right? So try to read the paper if you're interested in orthoscopic treatment. But what's important is this technique doesn't apply to most of your patients in India. Right? This is for clean septic arthritis. Just a option instead of doing a little incision, you can put a portal. All your periarticular abscesses, osteomyelitis, none of these can be treated, right? There's no advantage with the arthroscopic technique. So it's not very applicable to Indians, but I believe in it. It's better wash out than open. So I do it pretty routinely.
Yeah, so that was my next question. You know, when we do an open arthrotomy, at times it becomes difficult to pass our dura between the acetabular cartilage and the head. We have to give manual traction. So to put a 2.7 mm scope, it might injure the articular cartilage, you know.
Right.
So that you answered that question.
Right.
And the other point which I found very surprising is they had to give 34 days antibiotics. Now in septic arthritis, we hardly have to give antibiotics for 5 days. When CRP should neutralize, then why they required to give antibiotics for so long? So that's again a question where they have already excluded the osteomyelitis patients. Shalin?
They have mentioned that they have given antibiotics for 34 days. So I also had this query, but they have mentioned a mean stay of 4 days only. So they might have given IV antibiotics for a range of 3 to 7 days.
But in septic arthritis, once the CRP normalizes, we stop any form of antibiotic. We don't give oral antibiotics too. There was a paper from Melbourne. So they give, when they see more than 50% fall in CRP, they stop antibiotics. Now that is a bit aggressive approach, that you don't give antibiotic till CRP, but there is a paper that when this initial CRP falls by more than 50%, then there is no need of antibiotic. The disease is regressing. But we have never given 34 days in isolated septic arthritis. What is your take, Prasad?
We routinely use 10 to 14 days of antibiotics. So the IV or PO doesn't matter. As long as the child is reliable, the family is reliable to give PO antibiotics, and we have a bug that's sensitive to the antibiotic, we switch to PO almost third, fourth day, or second or third day, right? As soon as you see the CRP coming down, but send them on orals. 14 days is my standard for septic arthritis, uncomplicated septic arthritis.
So my thing is I give for about a week. Once the CRP is normalized for just isolated septic arthritis. For osteomyelitis, of course, we give for longer time. Anyways, that's so. As Prasad concluded with his broad experience in isolated septic arthritis without associated osteomyelitis, which is again a challenge to identify, as we saw in Chinmay's paper. This arthroscopy is a good technique. So single portal, Prasad, so you see through that, and sometimes I felt that with arthroscopy, you just drain the capsule. And
right.
the thing,
So see what happens in single portal, you have the high flow, right? You have a 3-liter bag of fluid available. You run 20 cc's, it'll just distend the whole hip. You suck it up right away. It's like in and out, right? You won't think that it'll work well, but it works better than 2 portals. So you form a short circuit between the 2 portals. This one portal, you fill it and suck it out. You clear up the hip within like 3 or 4 cycles.
So if you have some intra-articular debris, then you have to use another portal.
Oh, absolutely, yeah. Add whatever you need to. What I'm saying is simple drainage. What you get with an open, say, a cruciform capsulotomy is something I can get with a single portal.
Yeah.
And I can thoroughly run fluid all over the hip.
Yeah.
Constantly moving it and put a drain to the same portal.
What I also thought is, in some joints, like for hip, when we are doing anterolateral arthrotomy, the infromedial part, we think that this is drained. We take it granted. but we don't see by our naked eyes. So
Right.
probably the arthroscope would show us that there is no the debris or sticky granulation tissue is there or not. So is it an advantage to visualize the whole joint, which we are not able to see?
Yes, you can see everything really nicely. You can even a younger child, you can pull the head apart and look inside also. It's not that difficult, but
So
that's
what-
under control. So if you lose your traction, you're not getting damaged. Like this guy is putting a medial portal and going in between the head. That's not good at all. And 2.7 scope is not a common thing in your hospital. And a 70-degree 2.7 scope is a very rarely used equipment. So it's not worth for you to invest in something like that.
Sometimes, you know what, I have also seen the granulation tissue is sticking underneath the synovium,
Yeah.
which we are not able to see. So sometimes I just blindly put my hemostat and bite to see, and sometimes we have some debris. So I think scope would be good in those joints where we are not able to see 360 degrees, like in big hips. Yeah.
And it's very easy to put a second port and put a shaver. It's not difficult at all. Just not required in a early septic arthritis.
So some papers have mentioned that medial side of the hip and neck would not be visible through anterolateral portal. So
I'll show it to you every time, my friend. I'll show it to you every time. I actually put 2 cases in the last 2 weeks in the hip arthroscopy group, in the WhatsApp group. Look at those images, or I'll be happy to send you the images.
Yeah. So I always tell that at Orthokids, you won't see hip preservation. It's only every 6 monthly you'll see when Prasad comes. So those fellows who are interested, they can come down to your place and learn. Fine.
Sure.
So
All right,
thank you very much, Prasad, for your time.
Yeah.
Thanks everyone for nice presentation and all the delegates. See you next week with some other exciting meeting. Thank you. Take care.
Bye-bye.
thank you.